Hello, I'm Ben Church. I am the Wilderness Medicine Fellowship Director at Baystate Medical Center, and I'm going to be talking to you today about snake envenomation. So over the course of the next 30 to 35 minutes or so, we're going to briefly discuss the identification and distribution of snakes, both in Massachusetts and also nationally, and then spend the bulk of our time speaking on the clinical presentation, treatment, and antivenom administration, the stuff that you really need to know when you're dealing with a snakebite victim. The majority of the day today, or the next 30 to 35 minutes, is going to be discussing CROTALIDS or pit vipers. These include copperheads, rattlesnakes, and cottonmouths. To be complete, I have one slide on the Elapidae or coral snakes, but most commonly in the United States you're going to be dealing with CROTALIDS or pit viper envenomation. They have a hemotoxic venom, and there's approximately 9,000 cases every year of CROTALID snakebite envenomation. That's probably underreported. And there's about anywhere from a dozen to 24 deaths a year, about a handful of deaths. First, I want to go into a little bit about the CROTALID venom. We're going to be talking about the cytotoxic, hemorrhagic, and neurotoxic effects. CROTALID venom is a very complex substance with over 50 to 100 substances that are broadly classified into these three different categories. They are the cytotoxic effects, and that is the soft tissue swelling and pain and local edema effects. The substances that are involved with that are the metalloproteases and the phospholipases. They are responsible for the swelling, edema, and redness that are associated that you're going to see around the snakebite area. They activate tumor necrosis factor alpha, and they more or less hijack our own coagulation cascade. Swelling and subcutaneous hemorrhage can extend up through the extremities through the lymphatic systems, and a bite to the fingertip can produce swelling in the chest and the leg and can also result in pleural effusion and hemothoraces. Eventual hypovolemia and anemia from soft tissue edema and third spacing will occur. The hemorrhagic effects are the most feared complication of CROTALID envenomation. These are things like the internal hemorrhage, intracranial hemorrhages, retinal hemorrhages, thrombocytopenia, and eventual consumptive coagulopathy and DIC. This is the part of the snake venom that is going to give you your abnormal coagulation lab values that we'll talk about in just a little bit. DIC is rare and we don't see it very often, but it can nonetheless occur. When bleeding does occur, it is usually acute, it is severe, and is usually fatal. There is a case report of a woman who was bringing in her husband who was just bit by a rattlesnake, and he was getting weaker and weaker on the way to the hospital and had profuse amount of bloody vomit and bloody diarrhea, and the wife had told the physician that she knew that he was really in trouble when he started to bleed from his eyes. It was a statement that the physician noted was something that he would not easily forget. Luckily, the man did okay. Finally, there's the neurotoxic effects. These are not common in CROTALID species. They are really only going to be seen in the southwestern part of the United States. They are involved with the Mojave toxin A, but most commonly across the United States, you're not going to see this neurotoxic effects, really only in the southwestern part of the United States, but not in the majority of the US states. These are going to be things like your cranial neuropathies, fasciculation, and eventual flaccid paralysis. Some people may complain of a metallic taste in their mouth. The mechanism of this is pretty interesting. The venom directly binds to the calcium channel receptors on the presynaptic vesicles that contain acetylcholine at the neuromuscular junction, leading to a mass exocytosis and mass release of acetylcholine. This is where you get your initial fasciculations. They permanently bind to the cell membrane and do not allow for acetylcholine reuptake and recycling. Therefore, you have your flaccid paralysis. This is much what you would see with succinylcholine administration, so you can think of it like that. The reason that pit vipers are called pit vipers is because they contain what's called a pit organ in the front of their head. It's a nostril appearing structure that is a heat sensing structure that allows the snake to sense prey at nighttime and in the dark. I usually give this lecture to people in Massachusetts, so I'm going to focus on the endemic venomous species that live in Massachusetts, and then I'm going to go over at the very end about how you can find venomous species in your state. The two venomous snakes that live in Massachusetts are copperheads and timber rattlesnakes. Here you can see a copperhead that has the pit organ in the front, slit-like or cat-like eyes, a broad triangular shaped head with alternating patterns that are diamond or triangular shaped that are usually a rust or copper colored, but can be slightly lighter pink or a darker brown color. Again, this is the local herpetology atlas for timber rattlesnakes that live in Massachusetts, and you can see where the populations live in the area. And again, it's important to know this because it's either going to increase or decrease your clinical suspicion that someone has a crotalid envenomation. If you don't live in Massachusetts, this is the way that you're going to find what venomous species live in your state. The first thing you're going to want to do is go to the CROFAB website. From there, you type in your state, and they're going to give you the list of all the venomous snakes that live in your state. From there, you're just going to type a simple Google search, local herpetology atlas for, say, Tennessee, and from there, you are going to see all of the reptiles that live in that state, and from there, you're going to find the venomous snakes that you found on the CROFAB website, and you're going to get the map that corresponds to your state to see where the venomous snakes live in your area. This is a slide that I have on Elapidae snakes. They are not as common as crotalid envenomation, and they mainly live in the southeastern part of the United States. There's a mnemonic that goes that I think many people have heard of: red on yellow, kill a fellow, and red on black, friend of Jack. I don't find that mnemonic especially helpful. It is helpful and applicable really only in North America and the United States, but if you go to Central or South America or anywhere else in the world, there's multiple different patterns of red, black, and yellow that can be confusing. Also is a mnemonic red on yellow, friend of a fellow, red on yellow, kill a fellow? I'm not sure. So the mnemonic isn't as helpful. If you look at these two pictures here, the one on the right is a king snake, and that is a mimic and non-venomous snake, and the one on the left is the coral snake. What you should know about these snakes is that they don't have the front-facing fangs like crotalid snakes do. They actually have tiny little teeth that require them to chew on their victim for quite a long time before the venom is actually injected into their victim. It is a neurotoxic, has neurotoxic effects, leading to the fasciculations and flaccid paralysis associated with prolonged ventilator use. The antivenom doesn't really exist in the United States, except for a few places where there's high populations of endemic species of coral snakes. So let's switch gears a little bit and finish up and talk about the clinical and most important part of crotalid envenomation. We've discussed the distribution and identification of them. Now we're going to talk about the signs and symptoms and what to do when you have a snakebite victim. This slide comes from the Wilderness Medical Society guidelines, updated guidelines on crotalid envenomation. I don't find this particularly helpful. This is what you're going to find in a lot of text. It's a hodgepodge and large sum of all the different types of symptoms and signs you may see. The way I think about it is like this, and many toxicologists would agree. It's lumping, what they're called lumpers. They put symptoms together to be local or systemic effects. You're going to have initial pain, swelling, and erythema at the bite site, eventually leading to bullae, ecchymosis, and then you're going to move on to your systemic symptoms, things like nausea, vomiting, then eventual paresthesias, fasciculations if you're in the southwest part of the United States, and then the most feared complication, the coagulopathy. So what should you do if you or someone you know or you come across a snakebite victim in the wilderness? the first thing you should do, and I can't stress this enough, is you should leave it alone. Do not try to take a picture of it, do not try to capture it or kill it, leave it alone. There are many, many case reports of a snake bite victim attempting to capture or kill the snake, and they have given themselves another bite, sometimes in a worse spot like their face or around their neck or airway, or a friend or a family member has tried to capture or kill a snake and has made one victim into two. You should leave the snakes alone. Do not try to do anything with the snakes. If you are bit by a snake, the first thing that you should be trying to do is decide, do I need to evacuate? And if that is the case, you should evacuate and get yourself to a tertiary care facility and not try to do anything with the snake. If you have a real envenomation, the physicians at the facility will know based on your signs, symptoms, and laboratory values. This is a case from 2017, just as an example of a teenager who saw a rattlesnake. They killed it, chopped it up into 3 pieces, and it was dead. They picked up the decapitated head of the snake and they poked themselves with the fang on their finger. As you can see, their finger had ecchymotic and bullae extending up into their arm. They required antivenom and a prolonged hospital stay. Another case recently that was in Texas of a man who was bit in the foot by a rattlesnake and then killed the snake, decapitated it, and again picked it up and then poked himself and requiring higher doses of antivenom and put himself in a much worse spot. So really, leave the snakes alone. There has been a lot of historical field treatment that has been proven to be not only ineffective, but it's sometimes harmful. Of all the things on this slide, the only thing that you're going to want to do if you're treating a snake bite in the field is to immobilize the affected extremity. Things like electricity or lancing the wound, tourniquets, or sucking the venom out, which is still pretty common in the mainstream media, is not going to be effective. In fact, it may actually be harmful. There was a study that was done where they injected mock venom into a human model and then used commercially available extractors or oral suction, and were only able to get out 2% at the most of the venom, which is clinically insignificant. Toxicologists that I've spoken to have told me that the patients who have required broad-spectrum antibiotics, prolonged antibiotics, or antibiotics at all are the ones who have had someone try to suck the venom out. Human mouths are dirty. Do not try to suck the venom out of someone's wound. On top of that, the person who is sucking the venom out has also exposed themselves and is a possible second victim of envenomation. Lancing the wound or cutting the wound open to drain it has also really just shown to increase tissue damage in the area and inflammation, and has not shown to be any benefit. Tourniquets have been shown to increase gangrene and ischemia, and have been shown to actually lead to higher amputation rates and higher doses of antivenom requirement. If you do have someone who comes in with a tourniquet, what you really want to do is make sure that you have IV access and have the antivenom ready and about to run when you take the tourniquet down, because not only will there be a return of many of the ischemic byproducts, but a large bolus of snake venom. So you know what to do now when you come across a snakebite victim in the wilderness. What should you do in the tertiary care facility when someone comes to your emergency room? The first thing that you really want to do is pain control. And this is going to be with opiate pain medication, really not with NSAIDs. And this is because there is a theoretical risk of increased bleeding. You're going to want to remove the patient's rings, not only on the affected site, but also elsewhere on the body, removing any rings or jewelry in case there is swelling, which can cut off circulation. You want to mark the bite with a surgical pen every 15 to 30 minutes to look for progression. Update the patient's tetanus, and then observe them for 8 to 12 hours. And this are for patients who come in with a snake bite who have no symptoms. You want to observe them for 8 to 12 hours. If they come in and there's systemic signs, vital sign abnormalities, or they have abnormal coagulation studies, that's someone you're going to treat. But someone who comes in and says, I was bit by a snake, and they look pretty well, you want to observe them for 8 to 12 hours. There's no great literature on this. 8 hours is sort of the standard. There have been case reports of someone coming in with delayed coagulopathy at 11 hours and change, so 12 hours is the most conservative approach. It's all going to depend on your clinical suspicion. If you think that someone really was in an endemic area and may have been bit by a snake but doesn't have any symptoms, 12 hours is probably the best approach to observe them for before you can safely discharge them with normal vital signs, normal exam, and normal coagulation studies. You're going to want to work these patients up with a CBC, looking at their hemoglobin and hematocrit, as well as their platelet counts, their INR, PTT, D-dimer, which is the most sensitive test, looking for snakebite envenomation, fibrinogen levels, as well as a CK and type-in screen. What's interesting about platelet levels and fibrinogen is that platelets actually seem to hide in the blood vessels and within the spleen, meaning they marginate, because they bounce back very quickly after antivenom administration, as opposed to fibrinogen, which likely is used up and destroyed as the numbers take much longer to recover after antivenom administration. A good rule of thumb is if your platelet levels or fibrinogen levels are less than 150, you should treat with CroFab, which is what we're going to talk about over the next 10 minutes. So now we're going to spend the rest of our time talking about CroFab, what you need to know, how to administer it, and a little bit of background about it. Before I begin, I want to just reiterate that the reasons to give CroFab are those with systemic symptoms, those with abnormal coagulation studies, or those who have progressive local symptoms, swelling and ischemia that's moving up the extremity. To speak about CroFab, we do have to speak a little bit about its molecular structure. But before I go into that, I want to give a little bit of background about CroFab. It was originally an equine-derived therapy that was FDA approved in the year 2000 or so. And at that time, it was a whole IgG molecule that had both Fab fragments, which are the part that bind to the venom, and an Fc portion, which is the immunogenic portion of it. The equine-derived therapy had much higher rates of the side effects of serum sickness as well as anaphylaxis. This is important because the current therapy now is ovine-derived, meaning it comes from sheep and not from horses. That is important because it has markedly reduced the incidence of side effects down to less than 1%. So the serum sickness and the anaphylactic reactions are not really seen as commonly. And the reason for that is because the Fc portion was cleaved, and now it is only a Fab portion. The Fc portion that caused all these side effects has been cleaved, and now it's only Fab from the ovine-derived products. There is another product that's come out just a few years ago called Anavip, which is a direct competitor to CroFab. It has the same side effect profile. It is not as widely available because it is really new, but it has the benefit of having a longer half-life and is thought to actually prevent the delayed or recurrent coagulopathy because of its long half-life. The benefits of having the equine-derived therapy in the whole IgG was it was a large molecule that stuck around in the bloodstream for a very long time that allowed for more time to interact with the venom. The Fab fragments don't stick around as long, but they have a higher volume of distribution because it's a smaller molecule, so it gets to the little nooks and crannies of the tissue. It's important to note here that if you're going to give CroFab, you want to make sure that you're giving it based on the systemic symptoms and based on your coagulation studies, because up to one quarter to one third of snake bites can actually have something called a dry bite, meaning there is a snake bite, there is pain in the area, but there was no venom that was introduced into the body. This is important to know because you don't want to expose the patient to the risks and the cost that come with CroFab administration. So you've decided now that you're going to give CroFab. The patient has progressive local symptoms, they have systemic symptoms, or they have abnormal coagulation studies. How do you give CroFab? CroFab comes as a powder, and you're going to reconstitute it in about 250 cc's of saline. Your initial dose is going to be between 4 to 6 vials, and there's no great information that says when to give 4, when to give 5, or when to give 6. For me, I'm going to give 6 vials for someone who's particularly ill or has large systemic symptoms or hemodynamic instability, and maybe 4 for someone who's not particularly ill but who has progressive local symptoms. Once you reconstitute the CROFAB, you're going to want to give an initial dose of 25 cc's over 10 minutes. And this is because you're looking for this anaphylactic-like reaction. What you're looking for is wheezing, urticaria, hypotension, and gastrointestinal symptoms. What's important to note here is that CROFAB actually causes an anaphylactoid reaction and not an anaphylaxis reaction. That's important because anaphylaxis is a type 1 hypersensitivity IgE mediated response, whereas an anaphylactoid reaction is working directly on the basophils and mast cells to cause a large histamine release. The end result is an overwhelming histamine release, so you're going to be treating the same whether you're treating anaphylaxis or anaphylactoid. What's important is that you can and should restart the CROFAB for these patients because you would be doing them a disservice by saying they're allergic to the medication and stopping it. They would actually have worse outcomes. It is safe to restart this medication after an anaphylactic-like reaction, what appears to be anaphylactic. You're going to want to restart it at a slower infusion. Normally you give it over 1 hour. At this point you'd want to give it over 2 hours. You then, once you've given the medication, you want to observe them for 1 hour for progression. Either they're getting worse, they're getting better, or staying the same. So you're repeating coagulation studies, you're marking their swelling and edema, and checking for vital sign improvement. If they are the same or they've gotten worse, you want to repeat your dose of CROFAB, 4 to 6 vials again. Literature has shown that people need anywhere between 4 to upwards of 18 vials on any given time in the emergency department and over their hospital stay. It's also important to know about dosing is that children are going to require the same dose of CROFAB as adults. You're not going to be dosing on weight-based dosing. You're dosing based on how much venom you think the patient got. The only exception to that rule is very small infants, less than 10 kilograms, where volume is an issue. In that case, you're going to want to super concentrate the CROFAB and then give it over a 20 cc per kg bolus. And that's for very, very small children. I know that many of us think that poison control has some utility in some situation and no utility in other situation. This would be a place where poison control really would help you out. Not only for the ability to guide you when patients fall outside of the algorithm from the handout that I gave you earlier, the standardized algorithm, and they can guide you on special clinical scenarios, but it's for ensuring that we are recording and counting the number of snakebite that happen in the United States so that public health officials and policymakers can record those numbers. So I'd recommend that you call poison control if you have suspected crotolid envenomation. They'll help you in situations where there's bites to sensitive areas like the face and the airway, if you do have that anaphylactoid-like reaction. For the particularly ill patient who's not responding to CROFAB and is getting worse, who has life-threatening envenomation, high envenomation, or has evidence of shock. Last note is I want everyone to know that compartment syndrome that is caused from crotolid snakebite envenomation is treated with more and more CROFAB and not with surgical fasciotomy. This is something that is applicable to real life, but also for exam purposes. That it is important that you are not calling your surgeons for those who have evidence of compartment syndrome. It has been shown that patients have actually done worse with early fasciotomy. Not that fasciotomy is completely off the table, but you really do not want your surgeons to do this as first line. Make sure you're giving CROFAB, CROFAB, CROFAB until you come to the decision to do any kind of surgical fasciotomy. So take-home points. There are venomous snakes in your state. Look at the CROFAB website and then search your local herpetology atlas. Crotolid venom is extremely complex with cytotoxic, hemotoxic, and neurotoxic effects. Leave the snakes alone. Do not try to capture, kill, or take a picture of the snake. If you are bit, get yourself to a hospital. Do not use tourniquets. Do not suck the venom out of the wounds. Do not try to lance the wounds open. The only thing you want to do is immobilize the patient, keep them calm, and get them to a tertiary facility. You're going to want to observe patients who initially present with a snake bite without any symptoms for 8 to 12 hours to look for progression of symptoms, and work them up with a CBC, PT, PTT, fibrinogen, D-dimer, CK, and type and screen. You're going to treat patients if they have progressive local or systemic symptoms, or if they have abnormal coagulation labs. Repeat the dose of CroFab as necessary, 4 to 6 vials after 1 hour after administration. And remember that antivenom causes an anaphylactoid reaction and not an anaphylactic reaction. Compartment syndrome is treated with more antivenom and not surgical. Thank you.
Thank you, Dr. Church. That was a great review of something that we kind of all have to know, but just don't get to deal with very often, and so it's always unfamiliar when it comes in. Can I ask you a couple of questions?
Yeah, absolutely.
So are there any populations who, where you would have a lower threshold to give antivenom? The one always springs to mind is like pregnant patients. Often we treat differently because there's 2 patients involved.
Yeah, sure. So if you really think that a pregnant patient has been bit, I would have a lower threshold. There are situations where I have a lower threshold to give antivenom because we know that the antivenom is safe, and that if the patient does have a crotalid envenomation, the mother and the baby in the placenta are not going to do well if there really is an envenomation.
The one other question I had for you, you mentioned an 8 to 12 hour observation period in the asymptomatic patient?
Asymptomatic. So if someone comes in with progressive local symptoms, systemic symptoms, or any abnormal coagulation labs, that's an indication to treat and you do not need to wait. It's for someone who comes in with a bite, maybe there's a little bit of redness and pain in the area and you're not sure if it's real or not. You want to observe them for 8 to 12 hours before you think about any kind of disposition.
Do they get multiple lab draws during that time frame, or is it just an arrival set of labs and then observation?
I would do an arrival set of labs and then before they leave another set of labs at the end of the observation period. And at the same time, you want to be checking on them every hour or so for progression of symptoms. Keep them monitored, look for abnormal vital signs like hypotension or tachycardia, any systemic symptoms at all. But laboratory-wise, initial labs when they come in and then labs when they leave. Someone who's going to be discharged should have a normal exam, normal vital signs, and normal coagulation labs.
Thank you very much.
Yeah, thank you.